right, yeah, thank you. So I would like to thank the Vasculitis Foundation and the organizers of the symposium for inviting me to give a talk on medication and just kind of going through what's available for childhood vasculitis. I am a pediatric rheumatologist at Riley Hospital for Children, so here in Indianapolis, and had did a little bit of like vasculitis fellowship in Toronto. So I will stop my video as I'm talking, just so that you guys can focus on the slides. All right, so just to let everyone know that I will not be, because of time constraints, I won't be able to talk about all of the drugs that we use for vasculitis, just to. And then the drugs that I will be talking about largely are off-label drugs. So that means they are unapproved use of an approved drug. And that can mean that the drug is used for a disease or medical condition that is not approved. It is not approved to treat or given in a different way. So, approved for a capsule, but then it is being given as an oral solution or given in a different dose. So approved for 1 tablet once a day, but your doctor has been giving it 2 tablets once a day. Or 1 tablet or twice a day. And from the FDA's perspective, really, once the FDA approves a drug, healthcare providers generally can prescribe the drug for an unapproved use when they judge that it is medically appropriate for their patient. And so one reason is that, you may be wondering why a lot of doctors do this. One reason is because there might not be an approved drug to treat your disease or medical condition. And another reason is maybe that they have tried all approved treatments without seeing any benefits. So in situations like this, they will try a different drug used for other indications. And it is also important to know that before a drug can be approved, a company must submit clinical data and other information to the FDA for review. And the company must show that the drug is safe and effective for its intended use. So it's developing a drug for these companies can really be costly and time intensive. So here in the first phase, pre-discovery, drug discovery, and preclinical, all of that happens in the laboratory. So they'll screen a lot of different compounds, test it, in the lab, make sure that it has some function, and then move it to testing it in live animals. Once they have all of this data, they submit an investigational new drug application to the FDA. And after they get a go signal from them, that's the only time when it can be tested in humans. So this is where we are, what we call clinical trials. And there are many different phases of clinical trials. Phase 1 is, so largely they are wanting to know how safe the drug is. So safety is the main concern. They will test the drug at different dosing to make sure that they find the maximum effective dose without causing significant harm. After this, they move to phase 2, where they will recruit a lot more patients, a lot more volunteers, so 100 to 300 patients, and everyone will get the same dose, or sometimes, divided into 2 doses, and they will to make sure, and then they will test that these drugs are doing what it's supposed to do. Once they're done with this phase, they move to phase 3, and this is phase 3 clinical trials really is comparing the safety and effectiveness of the new treatment against current standard treatments. once, this takes about 6 to 7 years on average. And once they're done with this, they submit another application, new drug application to the FDA, and then they'll review it for some time, and then a drug gets approved. So from 5,000 compounds, 10,000 compounds, really one of them will get to this stage and become successful. And so obviously, the companies are reluctant to do these kinds of studies in rare disease because obviously they're thinking about, return of investment so much, it will, they will be compensated afterwards. But the government or the FDA has recognized that. And so they have implemented the Orphan Drug Act. So here, basically, they are giving incentives to companies if they studied a drug that's considered like rare disease. So they will be able to get like longer proprietary of the drug before it, exclusivity of the drug before it can be, before generic drugs can be made. And after launch of this Orphan Drug Act, more than 600 orphan drugs and biological drugs have been approved in the United States compared to just 10 in the decades before that. But this still does not address the concern in pediatrics in particular, because even after that, a lot of the companies still do not do a lot of testing in children. Drug development in children, and that's because there are so many things to consider. Some special ethical and medical considerations, small patient population that makes it challenging to recruit and enroll patients in clinical trials. And then, diseases in children are often like biologically different than those in adults, requiring special assessment of medicine safety and efficacy. And also they have to make certain formulations to make it more palatable and acceptable to children. And so a few years later, FDA did create new laws in order to support pediatric drug development. And these are the two of them. So PREA stands for Pediatric Research Equity Act, and PCA for Best Pharmaceuticals for Children's Act. So PREA basically allows FDA to require pediatric research for certain adult medicines, certain adult indications. And BPCA, so similar to the incentives that they give for the Orphan Drug Act, they give additional incentive to companies that will specifically study a certain drug for pediatric patients. And so really for us clinicians, these are the things that we kind of think about whenever we start someone on a medication. How many organs are affected, how severe the disease is this patient diagnosed in the hospital while admitted or in the outpatient setting, other comorbidities. We'll review the medical history to see if there's any contraindications to a particular drug, the age of the patients, and logistics too. Some of the drugs, I'm sure are given as an infusion, some oral, so really distance to the infusion center, and basically where you are in the world too, because you will find that there are different treatment guideline recommendations for each region, each country. And so really it depends on all these factors. And obviously we're always thinking about how we can balance the risk associated with existing therapies against the damage associated with undertreating or overtreating the patients. So all of these drugs have these things in common. So this is what we want. We want to reduce the effects of the overactive immune system. But as a consequence, we also will have, we will also be lowering the natural immunity of patients. That can be reflected sometimes in decreased blood counts. Symptom-wise, these patients may be more likely to develop symptoms of a cold or to pick up infections. And they should not be getting live vaccines such as measles, mumps, rubella, chickenpox, and yellow fever. So I will go through some drugs quickly, some extra important information for each particular drug. So cyclophosphamide, as Dr. Azathioprine has mentioned, is one of the drugs that we use for vasculitis. So it works by damaging the DNA or the genetic material of cells to stop or slow its growth. So it's given as a drip into the blood. So that's what we call IV infusion. Or as a tablet, but this is the IV route is really the preferred option that most of us do at the moment. These are the side effects associated with it: nausea and vomiting, hair thinning, mouth ulcers. Sometimes it can irritate the bladder and cause some blood in the urine. But what we do for that is we hydrate, we make sure that patients are drinking lots of fluid and peeing out, the medicines. It can also affect, menstrual cycles in females and sperm count in males. So there is a risk of infertility. And so in other centers, we would, talk to patients about fertility preservation. And there is also some increase in certain types of cancer, in particular, bladder cancer, but really cyclophosphamide will not be recommended for you unless the benefits of treatments are thought to be much greater than the risk. A lot of these medications too act right away. So for cyclophosphamide in particular, can take several weeks before you notice an improvement. The other drug is Rituximab. So it is it lowers a type of immune cells called B cells by binding to them, and that will reduce inflammation in the body. There's only one version of it, IV infusions, and most common side effect really is infusion reaction. That if it's going to happen, it's more common to happen in first or second infusion. It can also reduce the body's response to vaccines. How do we manage the side effects? So, usually your doctor will prescribe pre-treatment medication, pre-treatments, drugs such as Tylenol or Benadryl or steroids in order to decrease the side effects. This is one of the drugs that has an FDA approval, particularly for ANCA-associated vasculitis in children aged 2 years and older. And then steroids. So we all make steroids, but these are man-made steroids that is being given to patients to quickly reduce the inflammation. It's available in tablet liquids, IV infusions, or locally when we do joint injection to treat arthritis. The side effects really, you can have early side effect profile, which is different from the late side effect profile. So early on, these are the common side effects that you will see. But if you take steroids for a long period of time, then it can has a tendency to thin out your bones or develop cataracts or high blood pressure and high blood sugar. So really important for bone protection. We start patients on calcium and vitamin D, ask patients to make sure to eat a healthy diet and try to incorporate any amount of like physical activity on a regular basis. Take medicine with food to decrease the heartburn or stomach irritation, and it's like an annual eye screening. It is important to know that once you've taken the drug for at least more than 14 days, you cannot stop it right away. The drug has to be reduced slowly over a period of time in order to prevent withdrawal symptoms, such as like nausea or headache, vomiting, or low blood pressure. And then methotrexate. So methotrexate inhibits an enzyme that is needed to make the DNA or the genetic material. By doing so, it prevents cells, and by cells here we mean immune cells, from dividing, and that leads to an anti-inflammatory effect. It's available as a injection under the skin, subcutaneous injection, and pill form. Side effects includes nausea, vomiting, loss of appetite. Patients can sometimes have mild skin rash or increased sun sensitivity, mouth sores, minor hair loss and thinning, and may cause birth defects if taken during conception or pregnancy. And so we will prescribe folic acid tablets to patients in order to prevent some of these side effects. And for mouth sores, really good oral hygiene. If you have a sore, we recommend just like doing mouthwash with baking soda, taking methotrexate before going to bed or on the weekend will hopefully not cause a lot of stomach upset or like nausea, and then sun protection with regular use of sunscreen. Azathioprine works by disrupting the genetic material too of the cells, and again, same as methotrexate, this will stop the cells from dividing and producing new cells that can cause inflammation. It's only available as a tablet once or twice daily, and has a little similar side effect profile to methotrexate. This drug though has very rarely increased the risk of certain types of cancer, in particular like skin cancer and lymphoma. That's why we again tell our patients to use sunscreen, limit sun exposure. The drug could take about 6 to 12 weeks before the symptoms improve. And sometimes your doctor may check a blood time to know if you are adequately digesting the drug, and may adjust the dose of the drug based on that. Tocilizumab is a type of just like Rituximab, like a monoclonal antibody that blocks a natural protein in the body called IL-6 that's thought to be responsible for causing inflammation. It's available as an IV injection or under the skin injection. These are the side effect profile. Stomach aches, allergic reactions can increase the cholesterol levels and liver enzymes and cause high blood pressure. And these are the things that we try to do to manage some of these side effects. Another drug is Infliximab, so another monoclonal antibody that blocks a different protein, but that is also thought to be responsible for inflammation. There are many other drugs that work the same way, but I'm only listing one here. So this in particular is given as a drip through the vein.
You are in the meeting now. There are more than 30 participants in the meeting. This meeting is being recorded. You are muted. You can mute or unmute yourself by pressing *6.
And these are the side effect profiles, or infusion reactions, nausea, vomiting, and very rarely can cause drug-induced psoriasis and lupus, and also can put patients sometimes at higher risk for skin cancer, and that's because of
Kaylin. Dr. Go. Excuse me. Kaylin, you're we're getting feedback from you. Can you please mute? Okay, I keep muting Kaylin, so thank you, Dr. Go. Please go ahead. Sorry for the interruption.
Can put patients at higher risk for skin cancer due to sun sensitivity. So again, sun protection is very important in limiting sun exposure when on these drugs. So Mepolizumab is another monoclonal antibody that lowers the body's level of, again, another protein that is thought to be important in the survival of a certain type of cells called eosinophils. So this in particular has FDA approval for children at least 12 years of age for treatment of, when you look into the FDA, it says hypereosinophilic syndrome. They do not mention eosinophilic GPA in particular, but eosinophilic GPA can be considered a hypereosinophilic syndrome. And this is the last drug that I'm going to talk about, Avacopan. So it blocks the activity of the immune system called the complements to prevent it from attaching to the immune cells and cells that line the blood vessels. It comes in a capsule form. You take it twice a day. And, this is fairly new, just received FDA approval for ANCA-associated vasculitis in adults last year. It's not yet approved for pediatrics. And so what we know about side effects from the drugs right now are, based from, the phase 3 clinical trials from that study. We don't have like very long-term follow-up study data available. Going to skip this. So really, I'm going to end with this. I think just in general, just some tips that I have for families who are in this call, and make sure that you have enough drugs to last through weekends, holidays, or vacations. Always good to keep a list of all the medications that your child is on at all times. If a different doctor is wanting to start a new medicine, or for some reason you're undergoing some type of surgery, make sure to let your vasculitis doctor know. And if you forget to take a dose, contact your healthcare professional in charge of your care before, if you have to take the dose again, or do you need to just skip that dose for the day. Important to make sure that vaccines are up to date too, not just for the patient, but all household members, and just general like infection prevention with hand washing, always carrying antibacterial hand gels, proper food storage and handling, avoiding anyone who is sick, and good oral hygiene. And these are good resources for, just patient drug information. It's available out there.